Hello and welcome to this session of Maritime Medicine, in which we discuss eye diseases and emergencies. By the end of this session, you'll be able to perform a 10-point eye exam, identify at least 8 tools you need to perform an eye exam, identify the findings and treatment of the following eye injuries, identify the findings and treatments of the following eye disorders. So this is your eye, and we've got an anterior posterior looking straight on at the eye view on the left and a cross-sectional view of the eye on the right. So starting on the left, you've got your eyelids around the eyes and the bony orbit that surrounds them, and what you can see is the pupil, the black circle in the center, the iris, which is in this case brown, it's the colored section of the eye. It's covered by a clear covering called the cornea, which we'll see more in the other picture. And then a clear covering extends over the white of the eye. The white of the eye itself is called the sclera. The clear covering is called the conjunctiva. And the margin of the iris and the sclera is called the limbus, and that becomes relevant as we continue to discuss various diseases of the eye. Now if you look at the picture on the right, you've got an anterior chamber and a posterior chamber, the vitreous chamber. About 80% of the eye is in the orbit and is protected. About 20% is exposed. But the parts that are exposed are more or less connected to the entirety of the eye. They surround the eye, form the globe, and actually travel posteriorly along the optic nerve. It can also almost be thought of as an extension of the brain, of the meninges. So your anterior chamber is a small bump on the front of the eye formed by the cornea, which is clear in the front. Behind that is the anterior chamber itself, which is filled with aqueous humor, which is a fluid that the body continuously regenerates. It's produced, flows up through the iris and then down, around, and out the margins of the iris anteriorly where the cornea meets the iris, almost at the area of the limbus, if you want a general geographic area. The iris itself is the colored aperture of the lens. It opens and closes to let in more or less light and to focus. Behind that is the lens, which is suspended and forms basically the backside of the anterior chamber. Behind that is the posterior vitreous chamber filled with vitreous humor. That's not really regenerated. If that's lost, it's gone. The innermost lining of the posterior chamber is your retina, and that's essentially your photoreceptors. The images are projected on the retina and converted to electrical impulses that travel to the back of the brain and are interpreted as vision. And then you've got the choroid surrounding that, choroid plexus, and in that area, and then you've got the sclera around the outside, which extends again all the way to the front, but where it comes out to the outside world, it's covered with the conjunctiva, or conjunctiva, depending on how you want to pronounce it. So a patient comes to you with an eye complaint. My eye hurts, there's something in my eye, I woke up this morning, my eye looked red, I can't see from my eye. It could be any of a number of things. You need to do an ophthalmologic history. So you're going to do your general medical history as well, but things you want to know specifically to the eye. Is the vision normal, and is it normal in both eyes, and is it the same in both eyes if it's always the same, or if they wear glasses and they don't have their glasses, or they wear contacts and they took their contacts out, is it what you would expect it to be without your glasses or contacts? Is there a feeling like there's something in the eye? Does light bother your eye, and does light bother the eye that's bothering you if it shines directly into it, or does light shined into the other eye, the unaffected eye, cause pain in the affected eye? If it hurts when, or the light bothers it when light shines directly into it, that's called direct photophobia. When it hurts when light is shined into the unaffected eye, and the affected eye has pain even without light shining into it. That's called consensual photophobia. Was there an injury? Now or in the last few days? Have you been working with chemicals? Are you a contact lens wearer? Do you normally wear glasses? Has there been any drainage or discharge? How long has this been going on? Is it painful or painless? And painless doesn't necessarily mean not bad. There are plenty of painless eye conditions that are very bad. Have you had eye surgery before? Any history of diabetes or of glaucoma, increased pressure in the eyes, and any other prior eye disease or any other prior injuries? When you do your eye exam, you look generally at the face and around the eyes and look at the general appearance. Do the eyes look normal to you? We see a lot of eyes every day, and so how do these eyes look compared to others? Palpate around the eye. Touch the edge of the bony orbit. Touch the skin around the eye. Feel for warmth, tenderness, crepitus, other abnormalities. You need to check the visual acuity. If you have a Snellen chart, the things that hang up on the wall that have the big E on the top, that's useful. If you don't, there are plenty of apps, many of them free, that you can download that have visual acuity testing in them. If you don't have that, ask them to read a newspaper or magazine. If they can't read a newspaper or magazine, or they can't see anything with the charts, then do finger count. Stand back 3, 4, 6 feet, hold up your fingers, have them cover one eye and count your fingers, and then cover the other eye and at the same distance count your fingers. See if they're symmetric. If they can't count fingers, can they see them moving? If they can't see them moving, do they have any light perception at all? Cover up the unaffected eye, take a bright light and shine it in the affected eye. Can you perceive any light at all? If they can't perceive light, they are blind. There is no information being transmitted back through the nerve, the optic nerve, to the posterior part of the brain that processes those signals, or there's a problem in the posterior part of the brain, the occipital lobe itself, where that information is processed. Look at the lids and the lashes, and you need to invert the lids. You need to flip them inside out. The lower lids, it's easy. You pull down, you can see the inside of the lid. For the upper lid, you either need to put your finger or a cotton swab on the top of the lid, have the patient look down. Their lid will naturally drop down. Put the cotton swab right along the top of the crease where the lid reflects back from the orbit and towards the globe, and then take the eyelid by the lashes and lift upwards, and that will flip it inside out. Take a look at the white of the eye, the sclera. Is it white? Is it discolored? Is there any obvious injury to it? Take a look over that at the conjunctiva, the clear covering. Is it bloodshot? Is there blood underneath it? Is it discolored? Then look at the cornea, that smooth covering over the anterior chamber. It's the smooth bump right over the iris. And you're looking at it for signs of trauma or foreign bodies or any other finding. And then you're going to use fluorescein, which is a pretty harmless yellow dye that lights up under black light, but you can see it pretty well under regular light. And you put just a little bit on the lower lid, you have them blink, and you look and you see if that dye gets uptaken anywhere. And if it does, that's a sign of an injury. Look at the anterior chamber. Does it look like there's anything floating in it? Any blood? Is there layering at all? Look at the pupil. Does it react to light? What's its position? What's its position compared to the pupil on the other side? And what's the shape? If someone has a leak in the anterior chamber and fluid's leaking out, the pupil will often pull like a teardrop, with the pointy end of the teardrop pointed towards where the leakage is occurring. Are extraocular movements intact? That is, if you hold up your finger and have the patient follow your finger with their eyes, can they follow them left, right, up, down, and then can they converge? Can they follow your finger in towards their nose? And if there is any suspicion at all of a chemical exposure, you need to test the pH of the eye as well. There are some significant red flags, and this is aside from specific diseases like painless loss of vision. So in a patient who has an eye injury, who has a non-reactive or a dilated pupil, or an irregularly shaped pupil, or any blood in the lower half of the anterior chamber or completely surrounding the pupil, those are red flags for bad injury, and you need to arrange evacuation of that patient. If you've got a patient who has a painful red eye, who's a contact lens wearer, or vision changes on their exam, who has consensual photophobia, that is the light shined into the non-affected eye makes the affected eye hurt, or recently they've had a foreign body sensation in their eye and it went away, but now they've got aching pain in their eye again, or they've been hammering or grinding or working with metal, those are all very concerning, and you need to talk to medical control. Particularly with recent foreign bodies or hammering or grinding, they may have fired a small piece of metal through the globe and it's now lodged inside the anterior chamber or even in the posterior chamber or somewhere in the orbit and is causing a problem for them. And the wounds can be so small and the holes plug up so quickly that there may not be an obvious wound. What tools do you need to be able to examine an eye? Well, you need good lighting. You need a source of light. You'll always have a flashlight available. You may have an otoscope available. Hopefully you will, because that's the only way you can look in the ears as well and look easily up the nose. Ideally, you might have an ophthalmoscope. Those aren't necessarily too useful. You've got to practice a lot with those, and those are more for looking at the back part of the eye, looking at the retina and the other structures in the back. But if you have one, you can practice with it and learn how to use it. But a flashlight should be just fine for the exam you're going to do. A magnifying glass is very useful, particularly if you have a pair of loupes that you'd use to work on electronics, or the little jeweler's magnifying glasses that flip down and that are hands-free. Those are very helpful, so you have both hands available to work. You need soft tissue paper because you're going to make the patient tear up. Cotton swabs like Q-tips or something similar so that you can avert the eyelid and also for removing foreign bodies. A vision chart or something to test their visual acuity. Fluorescein strips, some pH paper, anesthetic eye drops, and the IMO has tetracaine 0.5% on their recommended medication list, and then some antibiotic eye drops and ointments. It's also nice to have artificial tears and a lubricating ointment as well, although you can kind of make do with antibiotic ointment if you have to. So I'm going to start with chemical exposure because this is one where you have got to start taking care of this patient immediately. Patient comes to you, they said, I just got chemicals in my eyes. 3 quick questions. Do you know where they came from? Do you know if they were acid or alkaline? And can you see? Just ask those questions and then boom, start irrigating. You're not going to do any exam. You're just going to start irrigating, and you're going to irrigate the eyes for 30 minutes. At some point in there, you're going to anesthetize the eye to make it more comfortable so that the irrigation is more effective. At some point, you're going to check the pH. At some point, you're going to talk to medical control. But the thing you need to do is get water flowing now to irrigate the eyes. So if you've got an eye wash station, that's the ideal. Get them leaning forward, get the eyes washed out. If you don't have an eye wash station, you can lean them backwards and flow water from a faucet if you can, or a shower head, although you want to make sure you're not flushing water from one eye to the other because the chemicals will flow with that and possibly contaminate a previously unaffected eye or other body parts. If you don't have those, you can spike a bag of normal saline, run the IV tubing down, tape it to the forehead over the bridge of the nose, and let the saline flow out and through the eyes. You can even attach that to a nasal cannula and tape the prong so one's on either side of the nose and it irrigates as well. But whatever you do, you just need to get fluid flowing. After about 30 minutes, you're going to check your pH again. If it's somewhere between 7 and 7.3, you're golden. If it's not, then you continue to irrigate. After that, antibiotic ointment and artificial tears. And at that point, you're going to be able to examine the eye, and they'll have a red, painful eye. You may see chemical burns on the face, and they may have vision changes. And if there's any significant injury, you will need to evacuate them. You may have to deal with eyelid lacerations. Trauma to the eye is very common, particularly for people wearing small frame glasses. The glasses get pushed backwards, the edge of the lens pops out, and it lacerates the eyelid. And the key to that is they've had trauma. You want to make sure they don't have vision changes, that their extraocular movements are intact, and that they have an otherwise normal exam. And then you look at the eyelid. And the eyelid is called the tarsus, the eyelid of superior and inferior tarsus. And inside of them they have this thing called a tarsal plate, which is essentially a ligament that gives them shape and helps them to move. And a laceration on the outside of the tarsal plate can typically be closed up, although you have to be able to do some pretty fine suturing to be able to do that and be very confident in your skills. If the laceration goes through the tarsal plate, you're essentially now creating an open pathway for infection in and around the orbit. And so those are things that need to be repaired by ophthalmologists or plastic surgeons. So your management will be gentle pressure. If there's any bleeding, don't push hard. You'll make the patient nauseated, give them a headache, make them pass out. So gentle pressure. Anesthetize the eye with some eye drops, the tetracaine. Remove any foreign bodies if there are any, and then talk to medical control. Again, the possibility exists that you could close this if you had a lot of experience doing suturing, but chances are good you're not going to do that. And if there's a tarsal plate injury, you're not going to do that. And you'll need to treat them with oral and topical antibiotics because you won't know for sure whether or not there was penetration through the tarsal plate, and if there was, the risk of an orbital cellulitis is pretty high. Corneal abrasions or brush burns to the cornea, and they can happen because of foreign bodies or direct trauma hitting something, contact lenses, particularly if they dry onto the eye and they get pulled off, or if somebody is given the numbing medication to take home with them, which you should never ever do. Don't ever let a patient leave with your topical anesthetic because they'll keep putting it in the eye and they'll rub the eye and their eye won't protect itself because it's numb, and then they'll end up with these kind of corneal abrasions and ultimately ulcers of the eye. So your findings are going to be an irregularity on the cornea, which you may need fluorescein to see. It's basically part of the cornea, the superficial layers have been stripped away. You put the fluorescein on and that area turns yellow and it flows off the rest of the surrounding area, and it will typically cause vision changes if it lays in front of the visual axis. So if you look at this picture, the arrow points to where the fluorescein has been taken up, and part of that is over the pupil. So the eye is seeing that and trying to focus on it, so you get both blurry vision, and because the eye is trying to focus on this thing that's just a few millimeters from the pupil, the ciliary muscles which control the iris can go into spasm and cause a lot of pain. So your treatment, flush the eye, make sure that you evert those eyelids, flip them inside out, make sure there's no foreign body up under there because those will continue to abrade the eyes, the cornea. Oral pain medications, including oral narcotics, may be necessary until they start to heal. And put on an antibiotic ointment, and they should heal within 24 to 72 hours. So you recheck them the next day. If it's completely healed, they can stop the antibiotic ointment. If it's not, they can continue it. But the pain gets much better, and the abrasion really heals. The cornea basically grows itself from the inside out, so the top layers are constantly sloughing off, and so those abrasions are very quickly sloughed off. Foreign bodies are very common in the eye. If you look at this patient's eye at about the 9 o'clock position, there's a small metallic foreign body, that black thing with a little bit of brown rust around it. So foreign bodies are a bit of something in the cornea or on the conjunctiva or under the lids, or they can be penetrating and go into the anterior chamber or all the way into the posterior chamber. And the presentation is typically a foreign body sensation in the eye, and if it's corneal, there'll be pain. These are very uncomfortable with vision changes. If it's a penetrating, small penetrating foreign body, there may not be any obvious wound, and it may just be significant aching in the eye itself. So the treatment is to rule out a penetrating globe injury, and this can be very difficult. If they have a history of hammering or grinding or working with metal, and you can't find anything on the exam, but they have a red eye and it's aching, then you need to be concerned about that and they need further evaluation. Anesthetize the eye. If the foreign body is on the conjunctiva or under the eyelid and it's loose, you can use a moistened cotton swab or a little bit of fluid irrigation. Either way, try to brush it away from the cornea so that you're not dragging it across the cornea and causing a corneal abrasion. If it's slightly embedded and it's very small, we're not talking about big foreign bodies, but just a little flake of rust that's just stuck in the conjunctiva, you might be able to pluck it out with a pair of tweezers or pickups, or if it's on the bottom of the lid, you might be able to just pluck it right off. But if you have any concerns that it's a penetrating object that's more than just a superficially embedded object, don't do anything with it because you don't want to remove a deeply penetrating object that's in the anterior or posterior chamber. On the cornea, if it's loose, you want to try to use a moistened cotton swab or irrigation to wash it off. If it's embedded, document the location. Make sure there's no findings of a penetrating globe injury, which we'll discuss shortly. Start them on an antibiotic ointment and recheck them on a daily basis. They need to see an eye doctor as soon as possible. If it's superficial, as the cornea grows out, it'll eventually push the foreign body out. But if it's penetrating all the way through, that may not happen. And then what we typically do to remove these is we use a binocular microscope to look up close, and then use a small needle to flick the foreign body out, and then may use a spinning burr to kind of grind away rust or anything else that's stuck in the cornea. Now, if someone has a globe rupture or penetrating eye injury, then you have much greater concern for them. And these can occur from blunt or penetrating trauma. Based on the mechanism of injury, you're suspicious for this. So the patient will have a painful red eye, they'll have had some trauma, they may have a pupil that's decreased in size, or it may not be reactive, or it may be irregularly shaped. So you look at this pupil here, and from the 9 o'clock to about the 5 o'clock position, it's nice and round and what you would expect. And then from the 5 o'clock to the 9 o'clock position, it's very irregular. It's got some rough margins, and it's straight, not curved. So that would be very concerning for a penetrating anterior chamber injury. You may see a laceration on the cornea. As you're examining the eye, it may feel soft to you. If it feels soft, you're done. Don't push it again. Don't have anybody else push it, because you may be causing aqueous or vitreous humor to leak out. You may actually see leaking fluid, and you may see what's called Seidel's sign, which is when you put the fluorescein on, the cornea is covered with a very slight yellow haze, and then where the fluid is leaking out, it looks like water trickling down through dust. So you see that little bit of disturbance through it. So this gentleman had had lens implants, so he'd had previous corneal surgery, and then he had blunt trauma to his left eye, and you can see around his left eye there's an abrasion just lateral to it and inferior to it. The right eye is normal in appearance for him. The left eye appears flat, it's dull. If you were to run your finger over it, you wouldn't feel the usual curve of the globe, and you can see that there's some injection in the conjunctiva as well. And in the center you see his CT, those are his eyes towards the top. On the right, which is the slide's left because this is a CT, that's patient right, you see the round globe with that bright white thing in the front. That bright white is the lens implant, and then that round thing is the globe. If you look on the left, the globe is completely decompressed and collapsing on itself. This gentleman has a stick impaled beside his eye. It turned out this was not a penetrating foreign body to the eye. It entered into the orbit and actually displaced the eye laterally, and then went through the sinuses and ended up penetrating into the brain. And in this case, you would expect that the eye would have a penetrating injury. Even if it doesn't, he has what's called orbital compartment syndrome, where the foreign body in the orbit is increasing the pressure there, it's squashing the eye, it's putting traction on the optic nerve, and can cause blindness even without going through the eye itself. And you can see just how dramatically that can present. If you look at the CAT scan, again, the right side of the slide as you're looking to it is patient's left, you can see the globe on his right that is round and there's nothing in the socket, and then the globe on the left is also round and looks like the globe on the right, but then there's that dark black thing at about the 9 o'clock position heading posterior through the nose and backwards, and that's the stick. So if you think they have a ruptured globe, protect the eye. Don't put pressure on the eye. Put a loose pad or a cup over the eye to protect it. If there's an impaled object, stabilize it. And then you need to cover the unaffected eye, because you have this system called the MLF that makes both your eyes track back and forth together. And unfortunately, even if you have an impaled foreign body, when your unaffected eye looks around, the affected eye moves. So you need to put a patch over the affected eye as well, so that it's not the unaffected eye as well, so it's not moving around the affected eye at the same time. Now that's going to be very scary because this person has just had an eye-threatening, possibly life-threatening, possibly career-ending event, and now you are effectively making them blind. So there needs to be a lot of psychological support, hold their hand, stay next to them, pain control to decrease their blood pressure, to make them more comfortable, and to control the pain, and then evacuation. In a blowout fracture, you suddenly increase pressure in the orbit, usually from blunt trauma, and it causes the thin bony walls of the orbit to rupture. So on this CAT scan, on the patient's left, you can see that black circle. That black circle is around the inferior wall of the left orbit, and it is blown out, and there is blood and muscle down into the sinus. You look at the sinus on the right underneath the orbit and the orbital wall there, it's black, it's completely empty. These are often associated with eye injury, and it's very hard to examine the eye because these people are getting hit in the face and they're getting a lot of swelling. Shipboard, you're going to be possibly the only person who gets the opportunity to examine this patient's eye, and so you need to do it. You need to basically grab the upper and lower lids, pull them open, look at the eye, look at the pupil reactivity, look for anything embedded in the eye, and ask them if they can see you. If they can see you, great. If they can't, let the eye go, take a very bright light and put it over the skin, right over the eyelids, and say, are you able to perceive light? If they have light perception, it means that the optic nerve is still intact. If they don't, it's probably not, and they're probably going to lose vision in that eye. Your big risks with these is because there's all that swelling, you might miss an eye injury, and so you need to make sure you examine the eye early before the swelling gets bad. And then not an immediate emergency, but you can see how that muscle is pushed down into the sinus. If it gets trapped there, it'll eventually break down, and then the patient's eyes won't move symmetrically. So you're going to find evidence of the trauma. Because the orbit is now less strong than it was, the globe may sink back into it. There's more volume in the orbit because it's extended into a sinus or somewhere else with this fracture. So the globe might sink in. The patient, because that muscle is trapped there, won't be able to necessarily move both eyes simultaneously. Now they can have a blowout fracture without muscle entrapment, in which case you wouldn't be able to tell. But if you have them follow your finger with their eyes and one eye is moving around and the other eye is only moving a little bit, then you need, and that's the affected eye, then you need to think that there's some muscle entrapment on the affected side. If they don't have any other eye injury, their only visual complaint may be double vision because they can't converge their eyes. They can't bring them together to see things up close. So one eye comes in, the other eye stares straight ahead, and they see double vision. So talk to medical control. You'll need to evacuate if there's any signs of an eye injury or a suspected brain injury, or they have any other trauma from this. Otherwise, potentially, if you're comfortable with this and there's nothing else going on and medical control is comfortable, you may be able to just get them to a physician as soon as possible without having to do a full formal evacuation. But if there's any question at all that the eye itself is threatened, then you need to evacuate the patient. A hyphema is blood in the anterior chamber, so you look at this patient's eye and you can see the top of the iris, it's brown, the eye itself is injected, it's red, and the bottom half of the eye covering the pupil is full of a dark red substance, and that's blood. So this can happen from trauma or from disease. The patient notices this after the trauma. There may be visual changes. If that anterior chamber fills entirely with blood, what's called an 8-ball hyphema, they won't be able to see anything at all, and the eye will be uncomfortable to them because the pressure is increasing in the eye with the blood in there. The big problem with these, or one of the big problems, is that blood can clot and it can fill in the drains that drain the aqueous humor along the outside margins of the iris. And if that happens, that can cause an acute obstructive glaucoma. And if that happens, then the pressure goes up in the anterior chamber and the patient can go blind. So your treatment for this is elevate the head of the bed, loosely patch the eye, no blood thinners at all, and that includes no aspirin, no ibuprofen, nothing that affects the platelets. Give them other pain control, acetaminophen, narcotics, whatever you need to, but no aspirin, no ibuprofen, and get them to an eye doctor as soon as possible. And that may involve evacuation depending on how much blood there is. Being out on the ocean with salt and sun and wind and all that other stuff that tends to dry the eyes. Dry eyes are a big problem shipboard, and the symptoms are this sort of gritty feeling in your eyes. They're red and painful. It's both eyes, and these patients won't have any red flag findings. Their vision will be fine, and the treatment for this is artificial tears that soothe the eyes. If they wear contacts, ditch them. Get rid of them. They need to just wear their glasses because the contacts will continue to dry and irritate the eyes. Wear goggles or sunglasses to protect the eyes, and then talk to medical control. And chances are that you'll end up giving the patient an ophthalmic antibiotic ointment. The ointment soothes the eyes, makes it more comfortable, but it's also very difficult to distinguish this from an infectious conjunctivitis, and so to be sure the patient may be put onto an ophthalmic antibiotic ointment. Ultraviolet keratitis is essentially a sunburn of the cornea, and it's called sea blindness or snow blindness or welder's flash, and basically it's ultraviolet hitting the cornea, giving it a sunburn. They can get facial sunburn as well, where the light reflects in flat planes off of water. Sunlight reflects in flat planes. You can actually end up with this in just a few hours, and typically if that's the cause, you'll end up with a facial sunburn. If it's welder's flash, that can occur in seconds and you won't get any other burns with it. It's associated with photophobia. They have a headache, and every patient I've ever seen with this, they come in, they can barely keep their eyes open, they're squinty, they're red, and when you put the fluorescein on, they have this punctate keratitis, and that's that bottom image. All those little dots all over the cornea are basically tiny little burns on the cornea, and so they take up the fluorescein in that little dot pattern like that. And so these people are pretty miserable. The treatment is to prevent it if you can. Wear protective eyewear once it occurs, so dark sunglasses will make the eyes feel much better. Oral pain control and some artificial tears or ocular lubricant ointment will help quite a bit for controlling the symptoms. And of course, your cornea heals so quickly that you feel better within a day or so. But then you need to prevent it from happening again. Infectious conjunctivitis is very common. It's an infection of that clear covering over the white of the eye. It can be from viruses or bacteria. There can be other causes too, but viruses are the most common, probably 90%, and bacteria make up almost all the rest. There can be non-infectious causes of conjunctivitis, allergies, chemicals. If you remember that eye we just looked at, the conjunctiva had some injection in it as well, ultraviolet conjunctivitis, and any of a number of other things. Typically, the patients will have an itchy red eye or eyes. There's a clear discharge. If it's viral, it can be a thick, almost pus-like discharge. If it's bacterial, the vision is typically not affected because there's like blurriness because of the discharge, but it's the conjunctiva, not the cornea or the iris, the pupil that's affected. And they may have other symptoms. If they have upper respiratory tract infection symptoms, a cold, then you think viral. If they have an allergic runny nose and they're sneezing and they have seasonal allergies, then you think of an allergic cause for their conjunctivitis. So on your exam, the conjunctiva is injected, as you can see here. The limbus, that little circle right around the edge of the conjunctiva and the cornea, is spared. So it stays white. And you look at the eye there, you can see that there's conjunctival injection right up to the limbus, and the limbus itself is white. If it's not, that's concerning for other more severe disease, and we'll talk about some of those. They have normal visual acuity. I find that bacterial conjunctivitis often starts out unilateral and may stay unilateral, but people touch their eyes a lot, particularly when they're irritated. And then they touch their other eye and they spread what they've got. So oftentimes they'll end up being bilateral. For the viral, it's almost always bilateral. They just spread so easily. So the treatment, if it's allergic, a histamine blocker, there's some eye drops. The patient probably knows they have this problem and they can use their own medications. If it's viral, You use artificial tears for comfort. It's highly contagious. This is pink eye, and it will spread throughout your crew. And you will encourage really good hand washing, and you will tell everyone to wash their hands well and not touch their eyes, and it will still spread. So just be very vigilant about that. And if it's bacterial, you add an ophthalmic antibiotic drop or ointment. And when you talk to medical control, it's very hard to distinguish between viral and bacterial. And even though viral is much more common, most physicians still consider it reasonable to use an antibiotic drop on a viral conjunctivitis, even though they don't work. You could simply observe and see if they're getting better or not as well. And that'll be up to medical control. Subconjunctival hemorrhage is bleeding under the conjunctiva and above the sclera, so it's blood sitting on top of the white of the eye. It's very dramatic appearing. You look at that upper picture, and if you woke up with that one morning, you'd be very concerned about it. It usually follows some transient increase in pressure where the small blood vessels between the conjunctiva and the sclera break and they bleed. So sneezing or coughing or straining with bowel movements, vomiting, mild trauma. This is commonly seen in young adults after a night of very heavy partying and drinking alcohol and vomiting, and then they get these subconjunctival hemorrhages. Typically they're painless or just sort of a mildly irritated feeling in the eye. The vision's not affected. And they're really only concerning if there's other signs of bleeding. So if they say, yes, I've had bleeding when I brush my teeth, or I've noticed a lot of bruising too, then you worry about a bleeding disorder. And those images you're looking at, the upper image is day 1. The lower image is after a few weeks. It's had a chance to heal. There's still some blood under the conjunctiva there laterally. Medially, you see basically a fading bruise. That's what that yellow is. It's the breakdown of the hemoglobin. So your patient comes in, this is what their eye looks like. They're totally freaked out. They think that their brain is bleeding and trying to escape from their head through their eye. You need to reassure them. Check their blood pressure. Hypertension can be a risk factor for this. Their blood pressure will probably be up a little bit because they're jacked about having all this bleeding. So reassure them and recheck their blood pressure over time. And if these are recurrent, keep an eye on their blood pressure as well. People can get infections around the eyes. They can get periorbital and orbital cellulitis. A periorbital or preseptal cellulitis is an infection of the skin, a cellulitis anterior to the orbital septum. And what that is that's the dividing plane at the edge of the orbit that divides the tissues of the front of your face from the orbit itself. And that's a pretty good barrier to infection and trauma and invasive events, invasive organisms, but it's not perfect. In an orbital cellulitis, you actually have an infection around the eye, and it can be incredibly hard to differentiate the two without imaging studies, CAT scan or MRI, and sometimes it's very hard to differentiate even with those studies. So the presentation is red, hot, swollen, painful skin around the eye. And in periorbital cellulitis, there may be pain with extraocular movement, but usually not. You have them follow your finger with their eyes, and it doesn't hurt very much, or it's just a little sore. Typically, there are no vision changes because this is just skin infection. They'll have a fever because it is an infection, and they don't have any proptosis, which is where the eyeball looks like it's trying to escape from the orbit. And so that can happen if there's a lot of swelling behind the eye or if there's an abscess behind the eye. In orbital cellulitis, you've got that same redness and swelling around the eye. They will typically have pain with extraocular movement, although that's not 100% true. Typically, because there's so much inflammation around the muscles of the eye, it hurts when they look around. They will have vision changes eventually as the optic nerve is involved, or if there's a lot of swelling and abscess and the eye gets pushed forward and the optic nerve gets stretched. They'll have a fever, and they may have that proptosis, the eyeball trying to pop out of the head because of all the swelling behind it. So if you think that they've got orbital cellulitis or they've got periorbital cellulitis, but you can't be sure that there's nothing else going on, talk to medical control. Give them IV or IM ceftriaxone, which is the injectable antibiotic you have available as long as they're not allergic, pain control, and they need to be evacuated because they need further studies to figure out how extensive this is, and they may end up needing surgery if there's an abscess. They'll definitely need ongoing antibiotics. Acute glaucoma is a sudden increase in the pressure in the anterior chamber, and typically it's from blockage of the drains around the margin of the iris, like blood from the hyphema. It can occur from some medications, and the one that's going to be problematic for you is nasal ephedrine, which is used as a nasal decongestant. So somebody has a cold, they're using nasal ephedrine, and then all of a sudden they have this painful red eye. The limbus is not spared, so the redness is looks like a conjunctivitis, but it extends all the way to the cornea. They've got nausea and vomiting and a headache, and they get blurry vision as the lens gets distorted, and then finally vision loss. You're going to say, what the heck's going on? But it's this ephedrine. The pupil can become fixed or very poorly responsive, and it doesn't have to be dilated. It can be mid-position, but you compare it to the other eye, it's not reacting to light at all. And this is typically unilateral, although it can happen bilaterally from medications. So if you look at this patient, the patient's left eye, is normal. It's reactive to light. The patient's right eye, you can see, is in mid-position, slightly dilated, the pupil. It is not reactive to light, and there's some conjunctival injection. The patient complains of an aching discomfort in that eye with blurry vision. That's acute glaucoma. So the treatment for this, talk to medical control, make them rest. You want to try to decrease the pressure in the eye as much as possible, have them sit upright. If you have pilocarpine drops, 0.5% eye drops available every 15 to 30 minutes, those are administered. They dilate the pupil. They let the anterior chamber decompress a little bit. Give them anti-nausea medications because every time they vomit, they increase the pressure in their eye. So you want the vomiting to stop. Give them pain medications so they're more comfortable, their blood pressure comes down, and a range evacuation. They need emergent management of this issue. The eyelid can get infected, and there's a focal infection and a sort of chronic issue that we'll talk about. The focal infection is the hordeolum or stye, and that's an acute infection of either one of the oil glands or a sweat gland, the sebaceous glands, which make this sort of lubricating, cheesy material at the base of the eyelash. They can actually occur inside the lids as well, in which case they look like a little red bump. They're painful, they get very irritated, and they may drain spontaneously. They typically don't affect vision because except that they can be big enough to be in the way, and then the patient sees them. In a chalazion, you get a blockage of an oil gland in an eyelid, and they form a cyst, and that's chronic and typically painless. Their vision is affected because these things get big enough to actually cover part of the visual axis. But they can become super infected. So if somebody has one of these and then suddenly one day it starts hurting them and it's red and tender, that means they've now developed an infection of that site. So on the left you see the hordeolum. Looks like a little pimple because that's essentially what it is. On the right you see that cystic structure, the chalazion, and that's basically starting to swell enough in that area that it's affecting the patient's ability to open their eye completely. So treatment for chalazion is none if they've had it for a while. If it's a new superinfection, it now hurts, it's red, it's tender, then antibiotic ointments. For the hordeolum, antibiotic ointments or drops. These will almost all spontaneously drain within 7 days, but you can encourage them to do it sooner by putting heat therapy to that eye. And the two ways to do it is you warm a spoon and dip a cloth in warm water, small spoon, you lay it over the eye, it sits in the orbit. The one I like is you hard boil an egg, you have it warm to about 100 to 110 degrees Fahrenheit or 38 to 42 Celsius, so it's nice and warm, and you lay it right on that eye over a cloth, and so wrapped in cloth, lays right in the socket. It fits about perfectly. It encourages the stye to drain, and when it cools down, the patient can eat it, so they get a snack out of their therapy as well. Retinal detachment is something you need to be concerned about as well. This is basically detachment of the retina from the choroid, so it pulls off the wall and the underlying structure of the globe. And remember, that's the screen onto which all the light from the outside world is projected. So that's where vision essentially is processed. And so it starts locally, maybe with a small tear or with a buckle, but then rapidly spreads as it pulls off the wall. It's typically unilateral, although it can be bilateral. it's painless because there's no trauma or inflammation. It's just this layer peeling off the inner wall into the posterior chamber. It can occur after trauma up to a month later, so a patient may have had a head or eye trauma a month ago and now suddenly complains of visual changes. That's very concerning. And typically it starts with a tear, but again, there can be a small buckle as well. And these present with sudden vision changes. So flashers and floaters are the big things. These people see flashes of light as the retina pulls off the wall. That traction is what's thought to cause the flashes. And then the floaters are small bits, either of retina or blood or other things in the posterior chamber that are now in the visual axis. So if somebody has a sudden increase in flashers and floaters, and that in and of itself should trigger alarm bells in your head for retinal detachment. If they report that things look distorted, straight lines look curved through that one eye, that's a sign of retinal detachment. They have a sense of a shadow crossing over their vision and then a veil pulling down over the vision, and then finally central vision loss, which can then be followed by complete visual loss. So this is an awesome image. You'll never see this. I'll never see this. This is the patient has had their eyes dilated, and you're looking in through a slit lamp binocular microscope. You can see the blood vessels of the posterior wall, and from about the 3 o'clock to the 5 o'clock position, you can see where the retina has detached from the wall. So talk to medical control, evacuate the patient. These need treatment within 24 to 72 hours to prevent vision loss. Now, patients may also present with sudden painless loss of vision. And this is really concerning. It can be permanent or temporary. Typically, it'll start with temporary episodes, what's called amaurosis fugax. So it's temporary loss of vision, unilateral. It's typically a vascular event. And then the vision comes back. And it only affects one eye. And it may occur more frequently, or it may be a first-time event for someone when they present to you. Typically, this precedes what ultimately happens, which is the central retinal artery occlusion. And then that's not this temporary, just a few minutes type of an event. And so you've got sudden unilateral vision loss. And essentially, these are TIAs, transient ischemic attacks, or strokes of the eye. The amaurosis fugax is a TIA. Central retinal artery occlusion is a stroke. And you need to talk to medical control. If it's persistent, the central retinal artery occlusion, you need to lay them flat on their back, massage the eye, see if you can break up some of the clots so that they fall, sort of flow further downstream, and so there's less vision loss, and evacuate them because they can get permanent vision loss within 100 minutes. So you really need to get them out of there pretty quickly. If it resolved, so it was there briefly and it's gone, then you think about aspirin, 325 milligrams daily, and a physician evaluation as soon as possible. And there's an ophthalmologic evaluation, but also they need a general medical evaluation to look for where these clots are coming from. Are they coming from the heart? Are they coming from the vessels in the neck? Why is this person throwing clots? Please complete any associated knowledge reviews, and if you have any questions, don't hesitate to contact your professor or instructor. Thank you very much.